So it's a pleasure to introduce David Schaeffer. It's a very important person doing a lot of good work in Vancouver. He's currently the head of his department in pathology there. And so he couldn't join us in person. He was planning to, but of course, some of those things are not always under our control. So he's going to be speaking remotely, and I believe we'll be able to see him. And his topic is WHO Blue Book, the new and the controversial. Dr. Schaeffer, thank you very much for joining us.
Thank you very much. Can you hear me okay? Great. Thank you so much for having me. And I am so unbelievably sorry that I'm not able to join you today in person. I was really looking forward to come and visit you and seeing your institution and be able to share and spend some time with you. But I'm hopeful that we'll be able to do that in the not so distant future. Also wanted to thank the Society and particularly Dr. Adey for inviting me. Dr. Adey at one point was my fellowship director, and I think there are very few honors in life, but to be asked by your teachers to present, and I think that's one of the biggest honors. So with that, thank you very much for having me. So I was asked to talk a bit about the WHO Blue Book and a bit of an open slate as to what I'm going to talk about. I do have some disclosures, but importantly, none of the material presented here will have any relationship to any of the commercial entities I'm affiliated with. Now, I am playing a bit of Zoom meeting with you today. I think we've all become very confident with the Zoom meeting bingo. But I promise I will unmute myself and we don't have to play it. And I wish I could say that part of the reason I didn't leave Vancouver is because it's always as beautiful as that. But unfortunately, if you can see behind me, it isn't always as beautiful as that. In fact, I think we are one of the few cities in the world that actually have a classification for our rain. And being a pathologist, and I know you are as well, you will appreciate the subclassification of rain. And so I hope that you will find some time at some point to come to Vancouver and hopefully not have to experience any type of rain. Okay, WHO Blue Book, the new and the controversial. So I think we've all come to love, and I don't think very much hate, because it's overall a very good new edition of the Digestive Systems Tumors in the 5th edition. For this talk, I've also combined some of aspects of the AGCC 8th edition. And as you know, the 9th edition of the AGCC, excuse me, is going to be organ specific. So there won't be a per se massive book any longer. There will be smaller chapters thereof. And for especially colon, the 9th edition is going to be imminently released. So I thought we're going to talk about some of the new terminology in the WHO. So gastric adenocarcinoma, and you already had some great talks this morning by Dr. Montgomery on the polyps. And then talk about a bit of Lamin and Hamin, because there's some new terminology in the WHO. Then focus on serrated lesions, talk a bit about colorectal cancer, and then finish off with some of the new terminology that you've already heard in the previous talk. But maybe highlight some of the features outside of the pancreas and neuroendocrine tumors. Okay, let's get going with gastric adenocarcinoma. So gastric carcinoma, I think we're all quite familiar with the traditional classification, Lauren, of the diffuse subtype of gastric adenocarcinoma, as well as the intestinal subtype. And that terminology is still quite useful in clinical practice. And what I'm showing you here is intestinal diffuse and indeterminate. And this is often what the discussions are with our clinical colleagues. But in the WHO, they have been defined more stringently as to what would fall into which category. And we don't have to go through this. I always like to highlight the hepatoid adenocarcinoma, the AFP producing one, in the gastric adenocarcinoma, but I'm sure most of you are quite familiar with that. Before we go into some new terminology in the 5th edition, I also wanted to raise the TCGA subclassification of gastric cancer. And that's really classifying gastric adenocarcinoma into EBV-associated, MSI-high, chromosomal instability, and genomically stable. And this is becoming more and more important because some of the treatment algorithms that our clinical oncology colleagues are using is based on what the overexpression of some of those markers are. So although this is just mentioned in a side note in the 5th edition, I thought it'd be important to raise it here as a subclassification in gastric carcinoma that is going to prove to become more and more applicable in day-to-day practice. Now, in the 4th edition, we had the entities of spindle cell carcinoma and cribriform comedotype adenocarcinoma. They have disappeared and they are no longer as part of subtypes. However, they have been replaced with carcinoma with sarcomatoid components, which I don't think needs very much explanation, and another entity which is known as adenoma-like adenocarcinoma. And so adenoma-like adenocarcinoma was described now 5 years ago in a very nice paper by Dr. Gonzalez and Dr. Shi. And these are entities that have 50% of invasive adenocarcinoma composed of villus structures with low-grade features. There's minimal desmoplasia and has this type of pushing growth pattern. And the incidence is reported to be around 3 to 9%, and they are quite a favorable prognosis, at least in this series, and had a very high KRAS mutation rate. And so there's, and we don't have to go through all of the pictures, but Dr. Gonzalez put some very nice pictures in here in this histopathology paper, and now being recognized in the WHO. If you do come across such an entity, just maybe have this in the back of your mind as one of the subtypes. Now, when we talk about gastric carcinoma, the question always comes up, when is it invasive? And you can see here, there's a very chronic active gastritis. I promise you there were maybe some helicobacters in the background, but here's this clearly dysplastic epithelium sitting over here. And the question is this already invasive or not? And here's a high power view of the cytological features, which I think all of us would agree have all of the hallmarks of a high-grade dysplastic lesion. Now, if you have not seen this paper yet, it's a great paper that is now also about 7 years old, but shows some of the work that has been done in Japan. And in fact, Dr. Lauers was very much involved in this paper as well. And it goes over the diagnostic criteria for gastric mucosal neoplasias between low-grade, high-grade, and then invasive carcinoma. And what I wanted to highlight in this paper is really that sometimes what we perceive in North America to be high-grade dysplasia may already be a laterally spreading invasive gastric adenocarcinoma. And Dr. Wiet from Germany gave a great talk about 2 years ago at the European Society of Pathology. And ever since then, it has changed my practice a bit. So I wanted to raise this paper to you if you're not aware yet of it. That goes through some of very nice different criteria to really highlight what makes low-grade and high-grade dysplasia in gastric adenocarcinoma. Moving swiftly on to appendiceal mucinous lesions. So that's definitely a new part of the WHO book and really stems from some of the work that was done by Norman Carr and as part of the peritoneal surface oncology international working group in a modified Delphi process. Now, I always teach my residents, and I thought it would be a good reminder to go over some of the terminology. So mucus is a slippery substance rich in mucin, which moistens and protects the mucous membranes. So mucus then is related to secreting, containing, or covered with mucus. Mucinous is a synonym with mucus, and myxoid, mucoid is resembling a mucus. And so sometimes when our trainees call it an appendiceal myxoid lesion, it's not wrong, but the proper terminology would be that of mucinous. So why bother with reclassification? I think there was quite a bit of debate of the proper nomenclature and classification, especially of PMP, pseudomyxoma peritonei. And there were some three-tier classifications out there. Others applied the terminology of borderline. And some others were even more in favor of just describing the gross appearance of PMP as mucinous ascites. And so the W2010 disagreed with all of those, but then some of those were reflected in the latest edition. The other big question that always comes up in appendiceal neoplasms is cystadenoma and MUCOCELE. And that's not a diagnostic term for appendiceal neoplasms in the WHO, and the use was also not recommended by the consensus paper of Dr. Carr. And to other classification schemes, that terminology may be used to refer to an intact appendix with mucinous adenoma, a serrated polyp, possibly even a low-grade appendiceal mucinous neoplasm forming a cystic mass, or others. So you can see that this is terminology that's really associated with so much confusion that, in my opinion, it's probably best avoided. So then lamin and low-grade appendiceal mucinous neoplasm, you're quite familiar with the definition of that undulating flat epithelial growth, the loss of the muscularis mucosae, the submucosal fibrosis, but not the desmoplasia, and then that's pushing diverticular-like type of invasion and the dissection of the appendiceal wall by the acellular mucin. And Hammond then is its cousin, but no longer has low-grade cytological features, but in fact now shows high-grade cytological features. And so it has the same architectural features as we would see in the lamin, plus has at least focal high-grade cytological dysplasia. And so importantly, that there's no infiltrative invasion in there, which would contrast it to an appendiceal adenocarcinoma. And the differentiation is quite important because in those centers where HIPAC, high-intensity peritoneal heated chemotherapy is given, a high-grade appendiceal mucinous neoplasm might bump this patient, depending on their overall status, to upfront systemic chemotherapy before actually being eligible for HIPAC. And then obviously the next stage in that whole cascade is the appendiceal adenocarcinoma, and this is mucinous. And there you have tumor budding, so those discohesive single tumor cells or clusters of up to 5 tumor cells and small irregular glands in a desmoplastic stroma. I just wanted to raise a couple of notes in here. And so appendiceal adenocarcinoma may be mucinous or non-mucinous, and the mucinous designation usually is given to lesions with more than 50% extracellular mucin, whereas the non-mucinous adenocarcinoma really resembles a colorectal adenocarcinoma of usual type. And then appendiceal adenocarcinoma can be low, intermediate, or high grade, and the degree of differentiation does not determine whether or not the designation adenocarcinoma is applied. So it's really the invasive component that makes it an adenocarcinoma. And then we have another classification that came about in the WHO fifth one, and that is the adenocarcinoma in the appendix with signet ring cells. And here you really subdivide them as poorly differentiated if your signet ring cells are less than 50%, and a mucinous signet ring cell adenocarcinoma if your signet ring cells are greater than 50% in the section that you have. And then pseudomyxoma peritonei, as you know, it's mucinous ascites, almost always originating from the appendix, although there are some tumors that can be from different organs, such as ovarian teratomas, colon, urachus, or pancreas. And that's characterized by slow but relentless interperitoneal accumulation of mucus and tumor, and typically without any lymph nodes or distant metastasis. And so in the 2016 paper, we really defined PMP that this is interperitoneal accumulation of mucus due to mucinous neoplasia characterized by the redistribution phenomenon. And it can include peritoneal implants. The mucinous ascites that we talked about may often involve, in our female patients, ovarian involvement. And as mentioned, most commonly from the appendix. And we all agreed that PMP should be considered to be a malignant condition. And so what is the redistribution phenomenon? Dr. Sugarbaker was a surgical oncologist and really a PMP pioneer who developed HIPAC and advocated for it. And there were two reasons for the redistribution of mucinous tumor cells in the peritoneum, and one that sides with lymphatic lacuna where the peritoneal fluid is reabsorbed, so omentum and the undersurface of right hemidiaphragm. Those are your high likelihoods of finding anything. So if you are in the frozen section room and you might be dealing with a more junior surgical colleague and they don't know where to go in the setting of a mucinous appendiceal lesion, the undersurface of the right hemidiaphragm is really the best area to look at. And then sites where tumor cells pools within the abdomen. So pelvis, right retrohepatic space, the left abdominal gutter as well around the ligament of Treitz. And the peristaltically active bowel are rarely involved by mucinous tumors. And we see that too in our growth specimens that we get. It's usually in the omentum, but not on the serosal surface of the small and large bowel. And so the staging group of advanced appendiceal tumors depends on the tumor grade, as we discussed. And then the 2016 consensus paper, this grading should apply to the peritoneal disease only, but not to the primary appendiceal neoplasms. So really there's a difference of a differentiation between staging the PMP, the pseudomyxoma peritonei, versus the appendiceal tumors. And I left that here for you in the handout to go over the notes of the staging. We don't really have to delve into that right now during the talk. Okay, moving on to serrated lesions and some of the updates on terminology, and then touch a bit about sessile serrated polyposis. So why care about serrated polyps? The serrated pathway makes up about 30% for sporadic colorectal cancers, so not an insignificant portion. FIT is likely not very useful in detecting serrated polyps, and we know that proximal serrated polyp detection rates is really related to the adenoma detection rate and the withdrawal time, and not so much to the FIT. And then, as you know, even within the GI pathology community, we still have only at best a moderate agreement in agreeing as to what serrated polyps subtypes there actually are. So here's my simplified view of the serrated pathway. So you have the normal mucosa and you develop an SSP, or as we determine the new terminology of SSL in a second, and it's usually by acquiring a BRAF mutation. You might go through the pathway of the microvillus hyperplastic polyp, and we'll talk about this in a second, then acquiring of cytological dysplasia by having different types of mutations, namely CpG DNA methylation, RNA 43 mutation, and then this would be MSI high colorectal cancer developing therefrom. And so we think that they probably develop from microvillus hyperplastic polyps, but MVHPs aren't completely innocuous. And so the transformation is likely a rare event. And therefore, we still do not subtype our hyperplastic polyps. And then, as we discussed, the serrated pathway is characterized by different mutations than those that do not go through the serrated pathway. So until the WHA came about, there was really a simplistic view of serrated lesions. You had your hyperplastic polyps. There was recognition that they could be subtyped, but as mentioned, not something that we're doing in clinical practice in microvesicular and goblet cell rich. Then there were the sessile serrated adenoma / polyp, SSA / P, and the traditional serrated adenomata. Now, with the WHO 5th edition, the recommended terminology changed. So it was now changed to sessile serrated lesion, SSL, and sessile serrated lesion with dysplasia, SSLD. So importantly, the terminology of cytological dysplasia was omitted. So this is the new view. So you now have about 5% of your SSLs will potentially have SSLD, so sessile serrated lesion with dysplasia. And there's also a new entity, much to my dismay, that was added, which is the serrated adenoma unclassified of about less than 1%. So my simplified view of this is that I have not yet diagnosed the serrated adenoma. So eventually I will get there, but probably if I keep it to less than 1% of my overall diagnosis, I will have covered that entity. So who gets serrated polyps? We know there's an increased risk. For some of our patients, we know that NSAIDs and increased physical activity in all likelihood decrease the risk of serrated polyps. So high BMI, high alcohol smokers, those are have demonstrated to have an increased risk of developing serrated polyps. So when we look at some of the clinical and pathological features, we know that the hyperplastic polyps are, albeit serrated, are more distally located than their proximal. And we know that the serrations are really limited to the upper 2/3 of the crypts. The crypts are elongated and straight, and the base of the crypts are uniform. There's no cytological dysplasia, and you have these microvesicular mucin droplets that we talked about. So here's a high power view of that. And I think we've all seen those sawtooths and serrations that are present on the surface. And really, if you think about it, it's a triangle that's put on its very tip. And that's how I explain it to our resident and fellows. You often get this thickened subepithelial collagen plate, sometimes in serrations. And especially in the goblet cell-rich hyperplastic polyps, that's often present. Now, the sessile serrated lesion, from a clinical perspective, is often larger than hyperplastic polyps and is often on a mucosal fold with a mucin cap. And in fact, that is how our clinical colleagues are being taught during endoscopy to recognize that they might be dealing with an SSL, knowing that there's this mucin cap on one of the house tool folds. And they are, as you know, more prevalent in the proximal colon than they are in the distal one. Now, they resemble the hyperplastic polyps with the serrated crypts and no cytological dysplasia, but the architecture differences. And so the serrations are present and along the entire length of some of the crypts, and the base of some of the crypts are dilated, irregular, and extended laterally. So here's a high power view thereof. And so really, if you think about it, the triangle is now no longer standing on its tip, but the base is present at the base, and this is where the elongations of the crypts come along. Here's another high power view thereof. And here I'm really showing you the difference of the microvesicular hyperplastic polyp in comparison to a prototypical SSL, where you have all of the features present on the right-hand side of the screen. And the reason for it being, if you think about it, is that the proliferation zone within the epithelium is differently located. In the hyperplastic polyp, it's at the base, so the proliferation moves upwards, whereas the proliferation zone in the SSLs is really within the center or in the mid part of the crypt, and therefore proliferation happens both upwards and downwards. In SSLs, you often see perineural stromal proliferation, and you may, and I promise this is the only EMA stain I will ever show, you can use an EMA stain to sometimes highlight that, and that is one of the features that is quite prominent and present in SSLs. SSLs also often occur over a lipoma. Sometimes it's not a true lipoma, it's more of an increase of adipocytes. And you often see this, especially at the ileocecal valve, where, as you know, there's more adipocytes more often present in the submucosa anyway. Now, one of the nice changes in the WHO was that you only need one unique, unequivocal architectural distorted, dilated, anti-horizontal branching crypt to make the diagnosis of an SSL. So before that, we had different criteria depending as to where we worked, of at least 2 size criteria. If you are a true believer in the WHO 2019, you can make the diagnosis based on a single architecturally changed crypt. So then what about dysplasia? We know about 5% harbor dysplasia. There's no point to separate them into high or low grade. But you must see dysplasia in the same fragment as the SSL to be certain that this represents true dysplasia rather than a separate conventional adenoma. MLH1 IHC may be helpful to separate fragments that contain SSL and dysplasia because MLH1 loss suggests SSLD. And so here I brought you an example of that SSLD present here. And you can see there's the dysplasia up top and actually the invasive adenocarcinoma already below it. And so as one of the latest kits on the block in terms of dysplasia is minimal deviation dysplasia in SLDs. And here MLH1 is of help because it's nicely lost in that setting. And here I brought you some MLH1 staining, and you can see that there's down here, there's this loss of MLH1. Full disclosure, it's very nice. It hasn't worked all the time in my clinical practice, but I have a lower threshold of ordering MLH1 in SSLDs these days. Now, we know that the risk of colorectal cancer is quite high, and there's some good data from a Danish study that really demonstrated that the adjusted odds ratio for an SSLD is 4.76 to develop a subsequent colorectal cancer, which is doubly as high as a conventional adenoma. And so therefore, there's a real need to identify those lesions. We don't have to go through this, but I leave it for you as well, that in the New Hampshire colonoscopy register, that odds ratio was even greater if they were greater than 1 centimeter. A quick word on serrated polyposis syndromes. So as you know, there are 2 criteria to make that diagnosis: at least 5 serrated lesions proximal to the rectum, all greater than 5 millimeters, with at least 2 being greater than 1 centimeter, or secondly, more than 20 serrated polyps of any size, but distributed throughout the large bowel with at least 5 proximal to the rectum. And that second criterion, they're additive. So they do not need to happen in a single colonoscopy. If you go in your colonoscopy in your histology record and you see that they all happened over the last 5 years, that would be sufficient. And that is important because in the WHO 4th edition, we had the criterion B, which required that there was at least 1 serrated polyp in the 1st degree relative to make the diagnosis of serrated polyposis syndrome. That has been omitted in the 5th edition. So therefore, the hereditary aspect of a patient is no longer required to make the diagnosis, meaning we can make the diagnosis. Now, as you know, serrated polyposis syndrome, there's no exocolonic manifestation, usually 5th to 6th decades. There's an unknown etiology still. We know there's 3% have an RNF43 mutation, but that has certainly not panned out. Any serrated polyp subtype counts, and polyp count is cumulative over multiple colonoscopies, as I mentioned. And it's not infrequent, 1 in 238 screening colonoscopies, and up to 30% develop colorectal cancer in the rectosigmoid, 50% thereof. So again, highlighting the fact that this is a serrated pathway. Okay, moving on to colorectal cancer. So whenever I give a colorectal cancer talk, I always start with this slide and refresh everybody on the margins in the colorectal cancer. And the circumferential margin is arguably the single most important factor for predicting the risk of local recurrence in patients, especially with rectal cancer. And I think we still have some, at least in my institution, areas to grow in our gross assessment thereof. So it's always just a reminder for everybody there. So with the AJCC 8th edition, as you know, we're back to a 4-tiered system. Gone are the days of low grade and high grade. And that was really based on the fact that although there wasn't huge differences in the overall survival, the AJCC felt that it was easier to stratify from a data capturing perspective colorectal cancer in the same fashion as other gastrointestinal carcinomas back to the 4-tiered system. Hence, we're now back to grade 1 to 4. One of the areas that has recently been a lot of focus on is venous invasion in colorectal cancer. And as you know, the presence of venous invasion really impacts the overall 5-year survival rate, even if you are in the same staging category. And the question always comes up, is H&E assessment sufficient? And this is a nice paper by our colleagues in Canada looking at some of the different ways of how to identify venous invasion in colorectal cancer. And they demonstrated that there's a huge variety in the venous invasion detection rate. And in fact, if we look across the ocean to our colleagues in the UK, 30% of venous invasion detection rate is a quality metrics. And next year, this is going to become a national standard in Canada as well, as we're now moving more and more into synoptic reporting guidelines. So if you only use H&E to assess venous invasion, you're probably hitting about 84%, whereas if you use a special stain, the 5-year survival rate in those study actually hit 96%. So demonstrating that H&E in itself isn't likely enough. And again, Dr. Messenger and Kirsch put out together this very nice paper talking about as to how to probably section your specimen accordingly to have your highest likelihood of identifying those mesocolic veins that might carry venous invasion within them. And it's become standard practice in my lab that we actually forego the H&E stain and we move directly to a MOVAT stain for those blocks that have the deepest point of invasion on gross examination of colorectal cancer, because arguably the venous invasion is so much more important in detecting than it is any of the other parameters that we could see with the H&E stain. Another area in colorectal cancer that deserves some discussion is T4A versus T3. And as you probably know, in the NCCN guidelines for high-risk factors for lymph node negative colorectal cancers, one of the parameters that determines whether a patient goes on to adjuvant chemotherapy is localized perforation, T4. And T4A is associated with decreased survival, will determine adjuvant therapy, and it's likely underdiagnosed. So 20% of those T3s are likely T4A. And again, in the UK and soon in Canada, PT4A is a quality metric that is being looked at, and the more than 20% is really where pathologists as a whole should fall into. So the AJCC8's addition of T4A characterizes these tumors by direct tumor extension of the serosal surface, and tumors with perforation in which the tumor cells are continuous with serosal surface through inflammation are also considered to be T4A. They then go on to state that the significance of tumor that are less than 1 millimeter from the serosal surface and accompanied by a serosal reaction is unclear, and multiple level sections and or additional tissue blocks should be examined. And so this goes back to Nicole Panarelli's famous scraping study, where she took a cohort of colorectal cancer patients and really subdivided them into a PT3 that had more than 1 millimeter from the serosal margin, and they had no reactions. They had nothing in the scraping that she then did on the surface, and there were no peritoneal recurrences on follow-up. Then those that were less than 1 millimeter from the serosal margin, they all had some sort of serosal reaction. About 50% had something in the scrapings and 11% had peritoneal recurrence. And then they drew PT4A, who had a similar spectrum as the ones that were less than 1 millimeter from the serosal margin. And so if you then apply common sense to those tumors that are less or equal to 1 millimeter with the reaction from the serosal surface, if that reaction consists of a small rim of fibrosis, then PT3, I think, is appropriate. But if there's only fibrin, inflammatory cells, and hyperplastic mesothelial cells that separates the tumor from the serosal surface, and one has done enough deeper levels, then PT4 is appropriate in this setting. And remember that PT4A is not applicable in non-peritonealized portions of the colorectum, so the posterior aspect of the ascending and descending colon and lower portions of the rectum, as I showed you in the very first slides of the margin of the colon in general. And so here's some examples of PT3. I think there's no question that we would all put this in the PT3 category, with your tumor over here and this very reactive serosal surface. Again, this is the ink tells the story, and there's a nice rim of fibrosis over here, so this would easily fall in the PT3 category. Now that is ink over here on some fibrin, and if you look, there might be some tumor cell over here that has ink on it. That would be, without question, a PT4A. That becomes a bit more challenging because you now are right here sitting at a cleft, but if we put this into high power view, I hope you agree with me that these mesothelial cells are only separated by this rim of inflammatory cells. There's no fibrosis present, so that in my books classifies to be in the PT4A category. We did a study about a year ago asking this very question within our province, and although the majority agreed with the standardized reporting or the standard interpretation of PT3 and PT4, we still have some ways to go, given that our kappa wasn't great. So I think there's always room for improvement in that area, and we have been putting a lot of focus on having digital image libraries to retrain or re-emphasize that topic. We don't have to go through the details of the study. Another aspect in colorectal cancer that deserves some attention is the definition of tumor deposits over time. So in the 6 editions, it was very clear. If we had smooth contours, we talked about lymph node metastasis. If we had irregular contours, we talked about a tumor deposit. In the 7th edition, we moved to a discrete foci of tumors found in the pericolorectal fat away from the leading edge, and we classified those as PT1C if no other lymph node metastasis is seen. Now, in the 8th edition, we added that if tumor is present within a large vessel or its remnant or surrounds a large nerve, then it should not be classified as a tumor deposit. And that becomes important because it changes the stage. So this is really this changes as mentioned between the 5th, 6th, and 7th edition. And so lymph node versus tumor deposit. So the shape it still helps you. Capsule, the peripheral lymphoid follicles are useful adjuncts in the diagnosis. And then, as mentioned, you must exclude perineural and venous invasion in the tumor deposit setting. So going back to that portion here, this influences the tumor staging. So if you have a T3 tumor with no lymph node metastasis, but with a discrete focus of tumor within the pericolonic fat away from the invasive front, so like this lesion right here, if you would be in the 7th edition, this would be classified as a tumor deposit. And the tumor would be staged as PT3 PN1C, so be a stage 3. However, if you pay close attention, you may recognize that we're actually dealing with a vasculature structure here in the center of it. And so given that remnant of the large vein, this would not be classified as a tumor deposit. And so this tumor would be staged as PT3N0, stage 2, which, as we've discussed earlier, would have from a follow-up for the patient quite different connotations. So as mentioned in the colorectum, we're back to a 2-grid grading scheme, and venous invasion, I think I've convinced you should be recorded in the resection specimens. I would be happy to discuss what you do in your lab as to whether you do elastic stain some fronts, and I'm very liberal in ordering CL sections for the serosal lymph nodes. Okay, moving on to neuroendocrine tumors. So as you know, there has been a word cluster for those lesions all the way back from oat cell carcinoma to apudoma, GP-net, islet cell carcinoma. But fortunately, with the WHO, first in 2017 in the pancreas and now adopted as well in the endocrine and now adopted as well in the WHO 2019 for GI, we hopefully have some more clarity on the terminology. So we are now in the neuroendocrine tumor grade 1, 2, and 3, and these are well-differentiated neuroendocrine neoplasms. And then a new category, or the category of neuroendocrine carcinoma, grade 3, which are either poorly differentiated large or small cell. And so there shall be no diagnosis of a neuroendocrine carcinoma without a large or small cell subclassifier thereof. And as the previous speaker mentioned, manic is no more, and my wife is a psychiatrist. That was one of the few things that we had in common. It is now back to, or it's now to MINN, the mixed neuroendocrine, non-neuroendocrine neoplasm. I put some highlights down here for the Ki-67 index, which, as you know, is based on at least 500 cells in an area of the highest nuclear labeling and should be counted in 50 high-power fields. But really, given that our field diameter is changing, be focused on millimeters squared, 0.2 millimeters squared. And the hotspot is what it's based on, but again, eyeballing is not necessarily recommended for making that diagnosis. So going into a bit more deeper detail as to how to subtype those. So grade 1 is less than 2 mitosis per 10 high power field, so less or equal than 2% on your Ki-67 index. And then 3 to 20% grade 2, and then the grade 3 for the well-differentiated neuroendocrine tumors is greater than 20%. And the grade 3 in the neuroendocrine carcinoma, and you can see the confusion that might easily arise, also is greater than 20% in the Ki-67 index. So why then have grade 3 twice? And it's really the belief, and the belief is backed up by some of the molecular studies, that there is good overlap between the well-differentiated neuroendocrine tumors and some well-differentiated neuroendocrine carcinomas, especially in the pancreas. So the terminology of grade 3 was applied to both of those entities. Now, a little bit about historical comments. You might hear it in my accent. I'm originally from Germany. And so Ki-67 was actually discovered in the city of Kiel, which is right up here on the Danish border. And so this is why it's Ki, referring to. And the 67 was the position on the 96 well plate. So Ki-67 giving reference every time we order the stain to the city of Kiel and the one master student who chose that position in the 96 well plate. So then in colorectal carcinoma, what is the nomenclature in the WHO 5th edition? So for the poorly differentiated neuroendocrine carcinoma, it's the small cell and large cell, and must have morphological characteristic of neuroendocrine carcinoma, as well as positive immunohistochemistry to make that diagnosis. The MINN is the mixed adeno and neuroendocrine carcinoma, and the mixed adeno and neuroendocrine tumor, although that is very rare. And each component must comprise at least 30% of the neoplasm. So if you have less than 30% of the neoplasm, you could not make the diagnosis of a mixed lesion, and then it might be an adenocarcinoma with neuroendocrine features. And here are some pictures thereof. I think this is we can all easily recognize that as a large cell subtype with that solid growth and a nice positive synaptophysin. And here's the small cell type with minimal cytoplasm, that nuclear molding, and the absent nucleoli that we know so well from lung biopsies. And again, the synaptophysin in the more speckled pattern being positive there. And here is a mixed adenocarcinoma, a MINN, so both cell types with the neuroendocrine and the adenocarcinoma component roughly comprising 50%, and nothing is as good as the synaptophysin, highlighting that over here. And I'm almost at the end here, but as you know, the neuroendocrine carcinomata actually have a higher frequency of BRAF V600E mutation in the setting of MMR protein deficiency, and this is a poor prognosis subgroup of colorectal cancer. They have a lower frequency of KRAS mutations, and the RB1 you can use in IHC is about 50% loss, but they're often retained in the glandular component. So if you do that, be aware of that, and can result in strong positive P16 expression. So it does not imply a human papillomavirus association there if you are P16 positive, but rather it's going down the other side of the pathway for RB1. And then anorectal neuroendocrine carcinomata should be evaluated for high-risk HPV on the other side. So there, P16 may be of help in that setting. And with that, thank you very much for giving me the opportunity to talk to you today.